Harvey and I are very happy to sponsor this morning's breakfast lecture. But before we begin, I would like to let all of you know that we are sponsoring Dr. Nathan Herrmann's talk in honor of our deceased Mayfair friend who died 1 year ago. His name was Alan Kravitz, and he was very much like Dr. Herrmann. He was an avid, serious exerciser, a quiet and dignified man, but he always made time to say hello, and he had a warm and sociable side as well. And with that, I won't take up any more of your time, and I'd like to welcome Dr. Herrmann.
Thank you very much, Laura. I hope everybody can hear me. So my name is Nathan Herrmann. I'm a geriatric psychiatrist from Sunnybrook Health Sciences Center, where I'm a full-time scientist in Hurwitz's Brain Sciences Research Program. And that means I spend all my time doing nothing but assessing, treating, and doing research on people with memory disorders. Mostly Alzheimer's disease and other related disorders, and we'll talk a little bit about what that means, but also people that have very mild memory problems that are very worried about their memories and fear that they may too someday develop Alzheimer's disease. So every University of Toronto professor, when they give a talk, has to do disclosures. I do a lot of clinical trials with the big drug companies that are developing drugs for Alzheimer's disease. I can tell you that they will not be happy with anything I have to say today, so you don't have to worry about those conflicts of interest. But you should know that I was asked specifically to make this an uplifting and empowering talk. And although I hope to do that, I think that you have to know your enemy before you can protect yourself from that enemy. So we will talk a little bit about the problems associated with memory difficulties in late life. So let's start with a few definitions. First of all, you'll hear me say the word cognitive impairment, or the words cognitive impairment quite frequently. So what does that mean? Cognitive impairment refers to difficulties with memory, particularly short-term memory when it comes to these problems that begin in late life. So for example, I frequently hear from families who are bringing their loved one for me to assess, say, you know, he can remember everything that happened to him in grade 5. This is an 85-year-old guy. He can remember everything that happened to him in grade 5, but he can't remember what happened to him 5 minutes ago. And that's short-term memory difficulties, and that's actually the most common kind of problem that I have to deal with. Eventually, the long-term memory goes as well. Other cognitive functions include things like language, the ability to express oneself, concentration, problem solving, and other kinds of areas. All things that we believe come from the brain. Now, the next word to define is dementia. Dementia is a broad term that describes many different illnesses. It's like saying, I've got the common cold. We know that the common cold is made up by thousands of different viruses. So the dementia is the term that refers to a group of illnesses where you have cognitive difficulties, like memory problems and language problems, functional difficulties, like the inability to do activities of daily living. So we have two kinds of activities of daily living we call instrumental activities of daily living, like being able to bang and use the telephone and use the washer dryer. Those are the higher level order activities of daily living. And then we have what's called basic activities of daily living, and that includes like bathing, dressing, grooming, feeding. So in dementia, eventually all of those activities begin to become impaired, and the person requires more and more help doing those. First, the instrumental activities require help, and eventually all the basic activities of daily living become impaired as well. And then finally, the other aspects, so we have cognitive abilities, functional abilities, and then behaviors, the third aspect of dementia. Virtually all people that develop dementia at some point in their illness will have some kind of change in behavior. It can be very subtle changes in personality. So, the quiet, reserved individual can become louder, more boisterous, maybe even rude in social circumstances. Or the person who is paranoid all their life and always suspicious of other people can become frankly delusional and talk about people stealing things from them. We can have frank delusions and persecutory delusions, like people stealing from you is one of the common types of delusions that we often see in dementia. Delusions of infidelity, so thinking that your spouse is having an affair, is also a not uncommon problem that we see in many people. These kinds of behaviors also include things like hallucinations. People hear or see things that aren't there, and people become agitated and even aggressive. Only a small number of individuals become aggressive, but that can become a very significant problem in looking after individuals with this dementia. So once again, cognitive problems, functional problems, and behavioral problems. Those make up the three constellation of behaviors that occur in people with dementia. Now, people always ask me, well, what's the difference between dementia and Alzheimer's disease? And the answer is that Alzheimer's disease is the most common cause of dementia. So everybody with Alzheimer's disease has dementia, but not everybody with dementia has Alzheimer's disease, because there's lots of different causes of dementia. But before we talk about the different causes, let me just tell you a little bit about how common it is. So we know in Canada, because there's been really good studies, that about 8 to 10% of people over the age of 65 will have dementia. And the risk for developing dementia doubles every 5 years after the age of 65. So aging, in and of itself, is the most important risk factor for developing dementia. About 20 to 30% of people over the age of 80 and 30 to 60%, depending on the study, of people over the age of 90 will have dementia. So this becomes a more and more common problem as people get older and older. And we know our society is aging, and we know, therefore, that these illnesses are becoming more and more common, and they are truly a big public health problem. About 50 to 60% of people, at least, in long-term care institutions like retirement homes and nursing homes, will have some form of dementia. It's estimated that at the moment there's about 250,000 individuals in Canada that have Alzheimer's disease, and by 2038 it's probably going to be over 1 million unless there's something that can be done to prevent or treat this illness. So, I mentioned that Alzheimer's disease is the most common, and I'm going to talk a lot more about Alzheimer's disease. But I also want you to know that there are other illnesses that cause dementia. So some of you may have heard of dementia being caused by strokes. These can be large strokes or even tiny strokes where the person may not even realize that they've had a stroke. It may have occurred at night, it may have been very subtle or very tiny, and only affects memory and doesn't cause limb paralysis or difficulties with sensation. So that's called vascular dementia. Another form is called frontotemporal dementia. Some people may have heard of Pick's disease. It's an uncommon but very troublesome type of dementia because it often occurs in people who are very young, like in their 50s and sometimes even in their late 40s. There's something called dementia with Lewy bodies, which is a combination of like Alzheimer's disease and Parkinson's disease all mixed up together. And Parkinson's disease itself, unfortunately, can cause cognitive impairment and dementia. There are a whole bunch of others. There's dementia from chronic alcohol abuse. There's dementia from nutritional deficits like B12 and folate. Brain tumors can cause dementia. Everybody's worried about brain tumors when they develop memory problems. That's a very, very rare cause of dementia, but it can be possible. Thyroid disease, particularly hypothyroidism, can cause dementia. There are many drugs that older individuals are on that can give you something that looks like dementia. So people who take sleeping pills, people who take over-the-counter sleeping pills in particular, these are people at very high risk of developing memory problems because of the drugs that they're taking. And that's one of my jobs, to do a very careful medical history when I see these individuals to make sure that there's nothing going on that can account for their memory difficulties that I can deal with very easily by stopping one of their medications. And finally, the last thing I'll mention very briefly is depression. Late life depression is a significant problem, and it can be associated with very significant memory difficulties. Many people that have depression in the throes of their illness will develop memory difficulties, and when you treat the depression, the memory problems can go away. Now, when I was training in geriatric psychiatry 30 years ago, we said this was wonderful because you treat the depression, and these people that looked like they had Alzheimer's disease, bang, they revert to being perfectly normal and they look great and there's no problem. But there is a problem, because we found that if you follow these individuals for 10 or 20 years, they will develop Alzheimer's disease at a very, very, very high rate. So there's something about developing depression in late life for the first time that puts you at risk for developing Alzheimer's disease. There's a bit of shared pathology. Okay, so let's talk a little bit about Alzheimer's disease. So as I said, Alzheimer's disease is by far the most common cause of dementia. At least 2/3 of individuals over the age of 65 who have dementia will have it caused by Alzheimer's disease. Typically occurs in mid to late life, so the typical onset is in people's 60s or 70s. But again, it becomes more and more common as people get older. Now, the important thing to remember is that while you develop the symptoms of Alzheimer's disease in your 60s, 70s, or 80s, the pathology, the brain pathology of Alzheimer's disease is starting probably about 20 years earlier than that. So it's likely starting in midlife, in people's 30s or 40s and 50s for sure. So the pathology starts way before the symptoms start, way before anybody knows that there's something going on. This usually has, once the diagnosis is made, people can live anywhere from 2 to 15 years. The progression is relentless. People start with cognitive impairment, they become more functionally impaired, and then they become more physically impaired. People eventually forget how to walk, they end up being bedbound, they have swallowing difficulties, and then they develop pneumonias and bed ulcers and all the things associated with becoming bedbound. People always ask me, well, I have a grandmother who had Alzheimer's disease. Am I at higher risk of developing Alzheimer's disease? And the answer is to some degree. And there's two types of Alzheimer's disease. There is a very, very, very small number of people that have something called familial Alzheimer's disease, where there is a very strong family history. In every generation, 50% of individuals have the illness. So if you have a big family, it's very easy to figure out. If you have a very small family, or if your family all perished in the Holocaust at the age of 20 or 30, then you wouldn't be able to detect this. But for many families, you can see the pattern very, very clearly, where 50% of individuals have it. But as I said, that's about 2% of individuals with Alzheimer's disease. It's a very, very small number. What about the other 95 to 98% of individuals that have Alzheimer's disease in their family? Well, the answer is yes. Even in those families, your risk is increased. It's not the same as having familial Alzheimer's disease, where you will have a 50% chance of developing the illness, but your risk is increased compared to people that have no family history of Alzheimer's disease. And people always ask me, well, how do you figure out risk? So, for example, in the general population, if you're 65 years of age or older, your chance of developing Alzheimer's disease, without knowing anything about you, I can tell you your chance of developing Alzheimer's disease is 1 to 2% per year. If you have a first-degree relative that has diagnosed Alzheimer's disease, like a mother or a father or a sibling, your chance is doubled or tripled. So your chance goes up to about 5% per year. Okay, so that's the kind of risks associated with Alzheimer's disease. The Alzheimer's Disease Society, or the Alzheimer's Society of Canada, has put out, and I highly recommend their website for any of you who have any interest in learning about dementias or memory difficulties in late life, has a great site. And one of the things they have is something called the Alzheimer's Society 10 Early Warning Signs. And this is a wonderful thing. It's not diagnostic, so don't try to diagnose yourself when you read these 10 early warning signs, but it gives you an idea about whether you should be worried enough to say to your family doctor, maybe I need to be assessed for this kind of problem. So I'll just read off the 10 early warning signs. Memory loss that affects daily function, difficulty with familiar tasks, problems with language, disorientation to time and place, poor or decreased judgment, problems with abstract thinking, misplacing things, changes in mood and behavior, changes in personality, and loss of initiative. So those are the 10 Alzheimer's Society early warning signs. Now, I also want to make it clear that there's a continuum that we're talking about. At one end of the spectrum, we have people that have normal cognitive aging. So what is normal cognitive aging? Looking around the room, I can tell you that I don't think there's anybody here who's younger than about 40, maybe 35. Anybody who reaches the age of about 40 will have had the experience of finding the right word difficulties, word finding difficulties, tip of the tongue phenomenon. That's perfectly normal. That's nothing to be concerned about. When it becomes a problem with your everyday speech in that almost every sentence you have, you're searching for the right word, that's when you need to be worried. But occasionally losing your words is not a big problem. So that's normal cognitive aging. The other thing we know about normal cognitive aging is that we're not as quick, we're not as sharp as we used to be. It takes us a little bit longer to think, it takes us a little bit longer to do the crossword puzzles or to play chess or those kinds of things. Again, cognitive stability is not a problem that we're worried about. The next problem becomes what we call subjective cognitive impairment. So these are people that are really doing very well in normal life, but they begin to get worried about their memory. And that's an interesting phenomenon. We can say, that person's just neurotic, they worry about everything, they're worried about their memory, it's just another one of the worries that they have in their life. But the interesting thing is, the studies have shown that if you have worry about your memory, you are more likely to develop Alzheimer's disease or other dementias than if you don't worry about your memory. The next, sorry guys, I'm just telling you what the research says, don't blame me. The next stage is what we call mild cognitive impairment. So these are people that not only worry about their memory and are aware about their memory not being as good as it used to be, but in fact, when you test them, their testing shows that they have mild memory difficulties. They're not having any trouble with activities of daily living, so they can still be working as lawyers and bankers and doctors, but they're worried about their memory problems, and there is definite evidence that their memory is not as good as it used to be. This is called mild cognitive impairment. Mild cognitive impairment is a very significant risk factor for developing dementia. So again, talk about the figures that I gave you before. We start with 1 to 2% per year of people over the age of 65 having a risk of developing dementia. If you have mild cognitive impairment, your risk is 12 to 15% per year. So in other words, if you follow these people for 5 years, about 50% of these individuals will eventually develop Alzheimer's disease. But that means 50% do not. And of the 50% that do not, about 20% of those actually get better. So it's not a sort of definitive diagnosis like saying this person has Alzheimer's disease where you know that there's no going back. Mild cognitive impairment is a significant risk factor, but it's not necessarily a death sentence to be done. The next step is mild dementia. And as I said, this is where people have the memory difficulties. They are already beginning to have difficulties in terms of their day-to-day life. They can't balance their checkbook anymore. They're getting lost when they go out. They're having trouble with their driving. They've made some errors while they're driving. They may have been involved in a motor vehicle collision. This is the stage of early or mild dementia. The interesting thing about mild dementia, and what often helps me decide when a patient goes from mild cognitive impairment to early dementia, is that again, a patient with mild cognitive impairment, they're worried about their memory. They know something's wrong. Once they've developed mild dementia, they say, there's nothing wrong with my memory, doctor. My memory's perfectly fine. It's no different than anybody else my age. When somebody comes to me to be tested, I know that that's a sign of them having a dementia. Finally, we get moderate Alzheimer's disease. It's not finally. Then we get moderate Alzheimer's disease. At this stage, basic activities of daily living become impaired, so people need help with their bathing, their toileting, their grooming, and they're having more and more difficulty expressing themselves. Severe dementia is where they are already becoming physically impaired as a result of the dementia. They are having trouble with their walking. They can no longer walk or ambulate safely, and they may end up becoming bedbound. And then finally, at the final stages of dementia, you lose all abilities. You can no longer speak, you can no longer do anything for yourself, you're completely dependent on your caregiver, and you're no longer walking and you end up in bed with all the consequences of being bedbound. And as I said, the course can go anywhere from 2 to 15 years. The course is getting a little bit longer because we are identifying dementia much earlier, at a much earlier stage. So the lifespan of people with dementia is actually growing. All right. So, as I said, we really try and focus on what we can do to prevent dementia. But again, let's make sure we all understand the risk factors. There are some risk factors we're going to be able to do something about, and there are some risk factors that we're not going to be able to do anything about. So obviously, getting older, we all want to get older, and that's the main risk factor for developing Alzheimer's disease and dementia. So we can't do anything about getting older. Genetics. Unfortunately, we have to live with what our parents gave us in terms of our genes. There's not much we can do about genetics. Gender. Also, most people can't do anything about their gender, but there is also, unfortunately, it's not that funny. There is an unfortunate discrepancy between males and females, where females are at higher risk of developing dementia, and that's for two reasons. First of all, as you know, in North America, females live on average 5 years longer than males. And again, at 5 years of added age just gives you 5 more years of potentially developing the dementia. But there's also another problem, and that probably has to do with circulating estrogen. Women lose circulating estrogen when they go through menopause. Men have estrogen circulating in their bodies all their life because testosterone is actually converted into estrogen in males' bodies. So we have that protective effect of estrogen throughout our life, while women do not. Now, the interesting thing about that is that led researchers about 20 years ago to say, well, if that's the case, why don't we just give women estrogen and we'll protect them from Alzheimer's disease? And there was this actually a couple of amazing studies, but some of you may have heard of the Women's Health Initiative study, which was a huge study in the United States of thousands and thousands of peri- and postmenopausal women who were randomized to receive either placebo or estrogen. And they thought that the estrogen would protect against heart disease, it would protect against stroke, it would protect against other types of cancer, not breast cancer. They knew that breast cancer might increase with estrogens. They knew that already. And they thought that it might protect against Alzheimer's disease. And I'm sure most of you know that the Women's Health Initiative study was horrendously negative. In fact, it showed that most of the things increased with estrogen replacement. And in fact, Alzheimer's disease and severe cognitive impairment was actually increased by giving estrogen rather than protecting the women against Alzheimer's disease. Education is a risk factor. If you have less than a high school formal education, you're at higher risk of developing Alzheimer's disease. If you have a head injury, you're more likely at risk for developing Alzheimer's disease. If you have depression, as I said, you are more likely to develop Alzheimer's disease. And finally, every risk factor that's known for heart disease and stroke is a risk factor for developing Alzheimer's disease. So high blood pressure, high blood sugar or diabetes, high cholesterol, obesity, smoking, physical inactivity, these are all risk factors for developing Alzheimer's disease. People ask me, well, why is that? How is it that blood pressure could have a problem, could be a problem for developing Alzheimer's disease? And the answer is, Alzheimer's disease is a very vascular disease. There's lots of vascular factors associated with it. And one of the fantastic studies that was done probably about 15 years ago, some of you may have heard of it in the press and the media, called the Nun study. There was an academic physician from Kentucky who managed to convince this whole order of Roman Catholic nuns across the United States to agree to detailed neuropsychological testing, neuroimaging on a regular basis, and then having their brains autopsied when they died for pathology of dementia. And one of the first findings of the Nun study was that regardless of how much Alzheimer's disease pathology you had in your brain, what determined whether in fact you had dementia in life or cognitive impairment in life was the vascular disease, was the small strokes, was the hardening of the arteries. That was actually what determined whether you had memory difficulty or not the amount of Alzheimer's disease pathology. So there's a very close relationship between cerebrovascular disease, atherosclerosis, arteriosclerosis, and Alzheimer's disease pathology. The last thing I'll say is, people always ask me about moderate alcohol intake, and there's a large debate about this. The epidemiological data is very clear that teetotalers and heavy alcoholics have very high risk for developing Alzheimer's disease, and then moderate drinkers have the lowest risk for developing Alzheimer's disease. So why is it that moderate alcohol intake can protect you from developing Alzheimer's disease? So there's lots of theories about this. Nobody knows. There's lots of theories about this. One of them has to do with a component of wine called resveratrol, which is maybe, it's an antioxidant and may protect against Alzheimer's disease pathology. But others say it's baloney. It has to do with psychosocial factors and not with biological factors. That if you have moderate alcohol intake, not high and not low, you're more likely to be a social person. You're more likely to be going out. You're going out to affairs, you're going out to bars, or going out dancing. So it's the other factors that are associated with moderate alcohol intake that is protecting you. It is not the alcohol intake per se. And again, from my perspective as a psychiatrist, that was where my training was. The minute I see somebody who has any degree of cognitive impairment or dementia, I say, it's abstinence. That is the key. You have to protect your brain from the toxic effects of alcohol. Okay, so I've told you all the risks, I've told you all the problems, I've told you how common it is, so the question is, what can we do about it? All right, let's talk about what doesn't work. So, the first thing that doesn't work, drugs. There is no drug that has been tried in the last 20 years that prevents people with no cognitive impairment or with mild cognitive impairment from developing Alzheimer's disease. And the drug companies have spent millions and billions and billions and billions of dollars, and they've looked at all kinds of different ways to try and prevent it, and nothing to date. Every single major trial has been negative. It's been very disappointing. I do these trials, and I can tell you, for 20 years to have one negative study after another can become very disappointing and very disheartening. So drugs do not work. Doesn't mean that tomorrow there will be a drug that seems to work, or the next day, or the next year, but at the moment it is very clear that nothing that has currently been studied makes a difference in terms of preventing or delaying the onset of Alzheimer's disease. People wonder about natural health products. So people have heard of Ginkgo Biloba. In Germany, Ginkgo Biloba is one of the most commonly prescribed or commonly taken medications. Now, it's a natural health product. It comes from the leaf of the ginkgo tree, which is one of the oldest fossilized trees that we're aware of. And they grind up the leaves and the stems, and they make this natural health product that is supposed to do all kinds of wondrous things, including preventing Alzheimer's disease. And in fact, there are a fair number of German studies that suggest it does improve cognitive abilities and it does prevent decline. The North American studies, North America took this very seriously, and there were big studies done in the United States and Canada looking at Ginkgo Biloba, and there is no evidence from the North American studies that Ginkgo Biloba works, and it's therefore not recommended as a treatment for Alzheimer's disease. Now, it's perfectly safe. If you want to try Ginkgo Biloba, I always tell my patients, go ahead, give it a try. What you should do, though, is be very careful about the preparation that you purchase, because every manufacturer's preparation, there's about 1,000 active ingredients in this smushing of leaves, ginkgo leaves together. There's about 1,000 active ingredients, and we have no clue what might be the active component of the ingredients. Every manufacturer's compound contains different amounts of those active ingredients compared to every other manufacturer's compound, and every lot number within every manufacturer's compound contains different active ingredients. So you never know what you're getting when you're taking a natural health product. That's the bottom line. So I just caution my families that I don't have much faith in it, but it's pretty safe. So if you want to try it, go ahead and try it. Vitamins and supplements. That's been looked at. B12, folate, all kinds of additional B-complex vitamins and other types of vitamins have been looked at, both naturalistically in terms of health database studies, as well as randomized controlled trials, and again, nothing seems to work. Omega-3 fatty acids. So you've all heard the story about fish, and we'll talk more about fish in a few minutes, but what about omega-3 fatty acids that you get in those capsules, those big red jelly capsules? Does that work? No, it doesn't work. There's some studies that are sort of semi-positive about fish oil. There's some that are very clearly negative. We actually just finished a study where we were using a very good preparation of omega-3 fatty acids to treat depression and cognitive impairment in people with coronary artery disease at Toronto Rehab. This was a double-blind randomized placebo-controlled trial, and we found it did absolutely nothing except give you fishy breath. People have asked me about coconut oil. For some reason, there's lots of information on the internet about coconut oil. No studies have shown that coconut oil is useful. Some people ask me about goji berry. No studies have shown that goji berries. So there's tons and tons of stuff. And at the end, I'm sure there's going to be lots of questions. You will all ask me about the favorite intervention that you've heard about, and I'm sure I will tell you there's no evidence that these interventions work. Okay, what does work? Here's the bad news for today. The bad news is that it's a brain-healthy lifestyle that works, and nobody wants to hear about what it takes to have a brain-healthy lifestyle. But if you want to know the truth, here they are. First of all, make sure you get a good education. Okay? A good education. And at least high school, if not some post-secondary education. Make sure that you wear a helmet when you go biking or when you go skiing. Protect your brain. Head injuries increase the risk of Alzheimer's disease. It's usually a significant head injury, one that causes loss of consciousness, like a concussion. That increases the risk of developing Alzheimer's disease. Make sure your family doctor is managing your vascular risk factors. Obesity, hypertension, diabetes, hyperlipidemia, stop smoking. These are all things that are absolutely essential. So what can you really do? We have to start with exercise. And as Laura said, she knows that I'm a very big exercise proponent. And I see my whole group of Mayfair colleagues at the table over there. So I know that lots of the people in this room believe in exercise as well. The best evidence there is to protect yourself against developing cognitive impairment or developing Alzheimer's disease is significant exercise. And it's a combination of both cardiovascular exercise and resistance training. What I tell my patients the first time I see them, I always give them the same speech about exercise. I say, I'm giving you an exercise prescription. I expect that the minimum you're going to do is the equivalent of a 20-minute walk every single day, enough to get yourself a little bit sweaty or a little bit short of breath, so it's difficult for you to talk. That's the absolute minimum. And then above that, it's a dose response. The more you do, the more type of exercise you do, the more protective it is. So, add some yoga, add some Tai Chi, add some exercise classes. Do some weightlifting, some gentle weightlifting, as well as swimming, biking, walking, running, whatever. But that's the combination. That is the best evidence that you can reduce your risk of developing cognitive impairment. This is not easy. I understand that. And a lot of my patients, they like to hear that there's something that you can do, but they feel that for one reason or another, and some are very legitimate reasons. I mean, if you obviously have unstable cardiac disease, it's going to be difficult for you to do that kind of a thing, although not impossible. If you've got severe arthritis and mobility issues, it's going to be difficult, but again, not impossible. There are ways to do exercise, and what I recommend is that you hire a personal trainer to get you started. There is a whole group of personal trainers out there that specialize in helping older individuals with multiple medical problems get started on an exercise program. It's a real growth industry. They specialize in this, and they do a very good job of getting people involved in exercise. So I think this is absolutely essential. So that's number one, exercise. I cannot say enough about exercise. Number two, mentally stimulating activities or mental exercise. So what does that mean? It means crossword puzzles, doing Sudoku puzzles, socializing, conversation, taking courses, adult education courses, like coming to hear me speak. You're helping your brains as you listen to me, if you manage to stay awake. Learning a new language has been shown actually to be very powerful at helping protect your brain. There was one study that suggested the more TV you watch, the more likely you are to develop cognitive impairment, because that's a passive activity. So don't watch TV. And then finally, there's something called cognitive remediation. And here, this is a very interesting area. So cognitive remediation, some of you who have access to the internet may have heard of something called Lumosity. Lumosity is this program that's available free on the internet, and you play all these kind of computer games, and they tell you how well you're doing, and you advance through it, and you do better, and you do better, and you do better. So the problem, and Lumosity is an example of cognitive remediation program, but Lumosity, the problem with Lumosity is that while you do better at Lumosity, you only do better at Lumosity, and it doesn't help anything that's happening in your day-to-day life. It really doesn't improve your memory to remember where you left your keys or your wallet. It doesn't do anything like that. It just helps you get better scores on Lumosity. However, there are very nice cognitive remediation programs. Baycrest has one, for instance, that's available, but there are a lot of commercially available programs as well that have been designed by neuropsychologists that really do appear to generalize to your activities of daily living. And we're studying one of these cognitive remediation programs at Sunnybrook. I'll tell you a little bit about that afterwards. Okay, so that's two of the three components: exercise, mentally stimulating activities, and the final one, again, these are all so difficult, it's diet. And we typically recommend a Mediterranean-type diet. So, much less or very little red meat, more fish, vegetables, legumes, fruits, nuts, especially almonds and walnuts. A handful of walnuts or almonds every day is a very good idea. And using olive oil as much as possible as your edible oil product. I want to tell you how important diet is. There was a fantastic study that was published in 2015 called PREDIMED. This was a randomized controlled trial of this type of Mediterranean diet. It was a supplemented Mediterranean diet, I'll tell you about that in a moment, that demonstrated a remarkably effective power of reducing the risk of developing cognitive impairment and Alzheimer's disease. It took a long time, it took 6.5 years to show this effect, so it's not going to happen tomorrow, you're not going to protect your brain tomorrow, but it was about between 27 and 36% chance of lowering your risk of developing dementia by adhering to this Mediterranean diet. The PREDIMED diet actually was supplemented with extra nuts and or extra olive oil, and people had to drink about that much olive oil a day. And I don't particularly love the taste of olive oil, so I can't imagine how I would do that. This is the way they designed the study. It may have worked just as well without the added extra olive oil or without the added nuts. They were trying to hedge their bets a bit, and so they added those extra things. So, but clearly, this kind of a diet, it makes a big difference. Now, we are clearly aware of these things. I'm sure it's not a surprise to you when I told you that the most important things you can do for yourself is exercise, mentally stimulating activities, and a Mediterranean type diet. You probably have all heard about this in the news. And in fact, there's evidence in North America, at least, that people are listening and people are hearing this. So whereas up until the 1990s, the incidence of dementia was increasing dramatically, the most recent study, and this was just published last month from the Framingham study, suggests that the incidence is now beginning to decline. And it may be beginning to decline because we are recognizing what a healthier lifestyle is, and people are adapting this. They may not be adapting it in the full ways that they should, but even small changes on a population level may be showing us that we can reduce the risk of Alzheimer's disease. And in terms of that, I'll tell you one other very interesting study. It's called FINGER. It's a Finnish study, very large Finnish study, where they're basically trying to introduce a brain-healthy lifestyle with exercise, mentally stimulating activities, and Mediterranean diet to a large group of Finnish elderly patients, compared to another group who are just told about the lifestyle. In the intervention group, they have people who are monitoring their activities, they're monitoring their exercise, they're helping them, they're getting them personal trainers, they're having them do cognitive remediation, they're having a nutritionist and a dietitian follow what they're actually eating. So they're comparing these two groups, and the first series, they're going to be following people for 5 to 10 years. But even after 2 years, the results are already very striking, that people that adhere to this are improving their cognitive abilities. It's not that they're not getting any worse, they're improving their cognitive abilities. So these are very, very powerful interventions. I would say probably more powerful than any drug I can imagine at the moment. And I would certainly recommend that if you haven't already started to adapt your lifestyle to a brain healthy lifestyle, that you should consider it. The one thing that I will end with, because of course there's no such thing as a free lunch, is a bit of an advertisement for my research. I work at Sunnybrook, as I said, in the Brain Sciences program, and besides running trials for Alzheimer's disease patients with new therapeutic drugs, and we're always looking for patients with Alzheimer's disease who are willing to go into a clinical trial, we have also started doing research on patients with mild cognitive impairment. So individuals that do not have dementia, but have mild memory difficulties, that is not interfering with their activities of daily living, but they're worried about their memory and they are at risk, as I told you before, of developing Alzheimer's disease. And so we have a very large study funded by Brain Canada, where we are putting people through an 8-week course of cognitive remediation and something called Transcranial direct current stimulation, which is a low dose energy brain stimulation technique that we believe helps them do the cognitive remediation better. We're giving them this 8-week course. It's half a day for 5 days a week for 8 weeks, so it's a really intensive course. And then we're following people for 5 years to see if that kind of an intervention can stop the development of Alzheimer's disease. So if any of you are interested, or if anybody of you know people who might be interested, or interested in any type of Alzheimer's disease research, please feel free to contact me. So that's my formal presentation. I think we have about 10 or 15 minutes for questions and discussion. Okay, Laura gets the first crack. She's sponsored.
I'm an avid duplicate bridge player, really enjoy the game. And my question to you is, it involves sitting. And according to your lecture, sitting is not terrific. So would you recommend that we be playing bridge on little treadmills?
Some people have called me a religious fanatic, but I'm certainly not a medical fanatic. I don't believe that you have to be engaged in physical activity 24 hours a day. That's not the case. I think everything in moderation is good. And even if you're sitting for 2 or 3 hours a day playing duplicate bridge, I think you're doing more help to your brain than harm to your brain from the sitting. Duplicate bridge is absolutely fantastic. It's very interesting because I see a lot of bridge. I'm in Sunnybrook, so a lot of my patients come from the North Toronto area, and it's a wealthier clientele than, say, some of my colleagues that work at St. Mike's, for instance. And a lot of my patients play bridge. And for me, bridge ability is a very sensitive indicator of cognitive abilities, because when my patients start telling me, my bridge partners don't want to play with me anymore, then I know that there's something wrong. So bridge is a good indicator. Bridge time ability. It's not always perfect, because I've seen some pretty impaired people still manage to play bridge. Now again, I don't know if their partners are very, very nice people. Bridge partners usually aren't. But I think it's a very good indicator, usually, of cognitive abilities. Yes, sir.
You made a couple of remarks about the fact that the level of education is important. That puzzled me, because physically having less education is not necessarily a factor. Is it fair to say that the lack of education has to do more with how you conduct your life after that?
So it's a very good question, a very good thought, and some of it has to do with that, but not all of it. What we believe is the most important factor is that when you're getting an education as a young individual, you are developing what we call cognitive reserve. Your brain is filling up with neurons and connections from the neurons from the educational process, so that when you eventually develop Alzheimer's disease, you have a lot more brain cells and brain connections than the individual that does not have a lot of formal education, and therefore you can survive with much more in the way of Alzheimer's disease pathology than individuals that do not have those brain connections. So it's both a lifestyle issue, there is some of that, but it's also something called cognitive reserve. Shelby, you had a question? Yeah.
2 questions actually. Do you support the conclusions of a lot of recent studies that CBD quantities in cannabis are effective in stopping
So I don't know if this is
Can you repeat the question?
Yeah, so my good friend from probably since we were 10 years of age, asked a question about CBD, or cannabis, let's put it that way, marijuana. There is some evidence that marijuana can be protective against Alzheimer's disease. There is a specific component in some of the cannabinoids that has very, very powerful antioxidant and very powerful anti-inflammatory effects. And there has been some preliminary evidence that suggests it can be protective. The reason I'm smiling is because I'm doing these studies on a synthetic cannabinoid at the moment to treat agitation and aggression in people with advanced Alzheimer's disease. And we believe that in this patient population, we can reduce agitation and aggression, improve appetite, and treat pain by using these medications, and at a much safer way than the current medications that are used to treat agitation and aggression. So thank you for asking me that question, Shannon. Whether cannabis itself or any kinds of cannabinoids will be helpful in the earlier stages of Alzheimer's disease to protect against the illness, I can't say, and my feeling is that it's probably not. It's probably not protective. But it needs to be seen. You had a second question?
Yeah, what percentage, if you're predisposed genetically to Alzheimer's, if you live the perfect lifestyle, eating Mediterranean diet, would you give a 20% reduction?
Yeah, I don't. Again, another very good question. So the question is, we know that your risk is doubled or tripled if you have a first-degree relative with Alzheimer's disease. So how much risk is mitigated by living that brain-healthy lifestyle? And the answer is we don't. It's a good question. Yes.
You spoke a little bit about mild cognitive impairment and the ability to carry on your day-to-day life and do your. Could you be a little more specific about signs or symptoms of mild cognitive impairment? What does that mean?
So again, you can be forgetful. So you may have trouble remembering a discussion that you had with somebody, or actually meeting somebody who you met recently. It can be something as subtle as misplacing an item every once in a while. Anything that has to do with short-term memory that you feel is worse. I mean, look, memory is variable. It's on a scale of individuals. Some people have fantastic memories or eidetic memories, and they remember everything they see. And there's people that all their life have terrible memories. So there's a scale, but it's what's changed for you. If you notice that you are more forgetful than you were 5 or 10 years ago, then that's the kind of thing that you'd be concerned about in terms of memory. Yes?
Genetics, because I always believe that I was predisposed to Alzheimer's. I don't think it's actually absent, so I don't carry the gene.
Okay, so okay. So the question is about these commercial genetic laboratories like 23andMe. And 23andMe, I don't think is actually testing you for the familial Alzheimer's disease gene. And if they're testing you for any Alzheimer's disease, it's for something called ApoE. ApoE is one of the genetic risk factors for Alzheimer's disease. It's a gene that is available in 3 types in the community. There's called ApoE2, ApoE3, and ApoE4. If you have 1 or 2 copies of ApoE4, you are at much higher risk of developing Alzheimer's disease. If you have 1 or 2 copies of ApoE2, you are at much lower risk of developing Alzheimer's disease. And if you have ApoE3, which is the vast majority of us in this room, then you are at either higher risk or lower risk. However, people with 2 copies of ApoE4 never develop Alzheimer's disease, and people with 2 copies of ApoE2 do develop Alzheimer's disease. So it's a genetic risk factor, but it is not definitive by any special imagination, and that is why the government doesn't pay for ApoE testing, because it's just not sensitive and valid enough. So I'm glad that they said you're not at risk, but that doesn't mean you're not at risk. Yes?
I have 2 questions. One has to do with socioeconomic status and how that affects Alzheimer's, and has it been shown in studies that people with lower socioeconomic status are at higher risk, and I guess that ties with education. And the other is about stress and how stress affects.
Okay, 2 good questions. Risks associated with socioeconomic status and risks associated with stress. So you actually alluded to the answer in your question about socioeconomic status. And the studies are very, very divided. And the problem with the studies on socioeconomic status is, A, they're difficult to do from a methodological perspective. How do you determine socioeconomic status on a large population basis? And I'll tell you how we do it when we do our studies using Ontario data. We look at postal codes. So we can determine socioeconomic status by the postal code in which a person lives. But obviously, that's not a very good, very exact method of determining socioeconomic status. It would be better if we had everybody's T4 slip, and we know that sometimes that doesn't even tell you what their socioeconomic status is. So all the studies have significant flaws, but in general, there does appear to be a suggestion that if you are at the lower socioeconomic status range, you are at higher risk, and higher risk for developing problems when you have the dementia, probably because you have less access to good and timely health care, or to medications, or to whatever, as well as all the other things like not having a good education and not being able to have mentally stimulating or physically stimulating activities. So there does seem to be some kind of relationship, but it's not as clear and it's not as strong as we might expect. The second question related to stress. This is also a very big question. Stress is no good for you. There's no question about that. It's that the more stress you're under, the more likely you're to have all kinds of medical problems. First of all, we know there's a very strong relationship between stress and depression in late life, or depression at any stage of life. If you're under stress, you are more likely to have lots of medical problems because your immunity is impaired as a result of the stress. And so, again, there is some suggestion that stressful lifestyle or stressful circumstances increases your risk of developing dementia. It's not as strong, and it's not as strong as because of all the other reasons that might be stronger in terms of causing the risk. But obviously stress is not good for you. If you can avoid it, do it. Yes?
You mentioned you're going to elaborate on fish.
Yeah. So we've known for probably 25 years that diets rich in fish, particularly cold water fish, seems to decrease the risk of cognitive impairment and decrease the risk of Alzheimer's disease. And people wondered why that is. And the obvious answer is that these cold water fish, fatty fish in particular, have lots of omega-3 fatty acids. The problem has been, as I said, despite 20 years of studies, and there's multiple studies, we have not been able to show that supplementing diets with omega-3 fatty acids makes a difference in terms of protecting against Alzheimer's disease. If you supplement diets with fish, it seems to be protective. But supplementing diets with omega-3 fatty acids does not seem to be effective. Why is that? Well, there are major components of omega-3 fatty acids. There is something called DHA, there's something called EPA. The components are very different. When you break them down into their individual component elements, it may be that one type of omega-3 fatty acid is protective, and another type is not protective, or maybe even somewhat harmful. So we're still not sure about the combinations of omega-3 fatty acids that will be protective. It's a good story. It looks very, very good in the epidemiological literature, but it is not shown to be helpful in terms of the supplements that you take by mouth or oral.
So there are, is there been studies, controlled studies relating fish to...
Again, nothing that I would call definitive. I mean, it's hard to do a randomized placebo-controlled fish intake study. But again, epidemiological data comparing people that eat high amounts of fish to those that do not eat high amounts of fish are suggestive that it has a protective effect. Yes, sir?
I used to be a high school math science teacher, and I would always get this question from students. I'm sure many of you as parents have also gotten this question. Why do I have to learn trig? I've never really used it in my life. When am I going to use algebra? When am I going to use French? When am I going to use Shakespeare? And my response was, it opens the neural pathways in your brain and improves your brain functioning. Now, I never related it, you mentioned that earlier, I never related it to dementia and Alzheimer's.
Yeah, but a 15-year-old kid couldn't care less. Tell them they'll get a better job, maybe they'll listen.
Is there an alternative to fish? I'm allergic to fish and all.
Me too. And again, we don't know if there's an alternative other than the other elements of the Mediterranean diet, like nuts and fruits and vegetables and things like that. They may be just as good as fish itself. Yes, sir?
Has there been any studies regarding stem cell research and Alzheimer's?
So yeah, there's some very preliminary study on stem cell research. It probably will not be ready for prime time for at least 20 or 30 years.
20 or 30.
Yes?
Just to clarify, you had indicated that the incidence or the risk is higher for women because the estrogen it's not circulating.
Correct.
And on the other hand, you said supplementing estrogen is not effective.
Right.
So how do you reconcile?
Yeah, so that's a good, how do you reconcile that factor, that supplementing? So in the Women's Health Initiative study, for instance, the supplementation was equine estrogens. You know that most estrogen preparations come from the urine of horses. Sorry, ladies, that's just the way it works. And there's a suggestion that perhaps that type of estrogen coverage is not protective or maybe even harmful. Perhaps a more natural kind of estrogen is what, and there are actually beta estradiols that are available. There's the patch. The patch happens to be much more natural estrogen than the equine estrogen. So that's one explanation. It's the preparation of estrogen that they use that may have been problematic. There's another theory that really for women, it's an issue of when they are exposed to the estrogen. There may be a specific window of time when it's protective and another window of time when it's harmful. And they haven't yet worked out what those correct windows of time are. Yes, sir?
You said that there's no drugs that are effective. What about the opposite? What drugs you may be taking for other issues?
Right.
Do they have any impact possibly?
Right. Right. So the question is about drugs. I said that there's no drugs that are helpful. Are there drugs that are likely to make things worse? And as I said in my presentation, yes, there are. And one of the classes of drugs are benzodiazepines. These are the Valium-type drugs that help people with their sleep. These are very commonly used in older individuals, and they can clearly impair short-term memory, as well as lead to falls, hip fractures, and other risks. They are also addictive and very difficult to stop once you've started taking them. So that is one class of medications that has clearly been shown to make things worse. But there's another type of side effect called anticholinergic effects that exist in many medications. So the old-fashioned antihistamines like Benadryl, a lot of the over-the-counter sleep products like Sleepies, Noda, or Dozies, or whatever, all of these have these anticholinergic side effects that cause dry mouth, blurred vision, constipation, urinary retention, and cognitive impairment, memory difficulties. So gravel, very bad for the brain. There are a large number of drugs that are potentially problematic, and as I said, that's one of the things that I look at when I do my drug review on my patients.
So is melatonin one of those?
No, melatonin is a natural, melatonin's an interesting thing. Melatonin is a hormone that is circulating naturally in our blood, and it helps with day-night cycles. And melatonin has been looked at a lot. It has a lot of potentially interesting characteristics that might be helpful. Basically, it's been found to do nothing for people with Alzheimer's disease. The only thing that melatonin has been shown to be helpful for are for shift phase sleeping problems. So people that work, at nights and then all of a sudden they have to revert back to a regular schedule, or for airline pilots that have to be up all night and then sleep, then want to sleep during the day. So for those kinds of sleep problems, melatonin can be helpful, but that's about the only thing, and there's been lots of randomized controlled trials, it's about the only thing that melatonin has been shown to be helpful for. And people also make a big mistake with melatonin. They think that higher doses work better. It's actually the actual opposite, that the lower the dose, the better. The physiological dose of melatonin is probably close to 0.5 milligram, 1 milligram, and people take 3, 5, 10 milligrams. That's useless. Yes?
You mentioned almonds and walnuts.
Yeah.
Does that apply to all the nut families, such as sunflower seeds, cashews?
Yeah, good question. So the answer is we're not 100% sure, and all of these nuts differ significantly in terms of their fat content. in terms of their cholesterol content, in terms of their energy content. We know for sure that walnuts and almonds seem to have the best combination of the omega-3 fatty acids and the right fat content. So those are the ones that we generally recommend. They're also a little bit better in terms of calories than, say, cashews, for instance. But it's probably all of the nuts and seeds are better for you than nothing. But again, you have to watch your calorie intake because you don't want to get obese on all this stuff. Yeah?
What about the advertising of food products that makes you think that they contain omega-3 such as eggs? Is that artificial? Is that natural? And what effect does that have on reducing your risk of Alzheimer's?
So again, we generally believe that to get the benefit of food, you need to eat the food and not the supplements. And as I said, this has been shown very clearly in the vitamin and supplement studies where people were given folate and B12 and other B-complex vitamins, and it does absolutely nothing. And again, we know from diet records, these things are helpful. So I would say that, don't eat those products and think that you're protecting your brain. Eat real, like if you're wanting to eat omega-3 fatty acids, then eat fish.
Well, what does omega-3 not appear naturally in eggs, or is it something that is artificial?
Oh, no, so actually I'm not sure about that. I'm not a dietitian. I don't know how much. I think those are supplemented. Those eggs you're being supplemented with omega-3. It's not natural.
I think it's the feed that they feed the chickens.
Flax
seeds. Yeah.
They feed them flax seeds.
So the answer was that it's probably in the feed that they feed the chickens, and therefore it gets into the eggs that way. Actually, it's 5 after. I think maybe we will end. If people have any questions that they'd like to ask me personally, please feel free to grab me during the meal. And make sure you pick good choices.
So on behalf of the Impairment and Continuing Education Committee, I'd like to thank everybody for coming this morning and enjoying this presentation. Thank you, Dr. Herrmann. And the food is there at the back. Go ahead, make your healthy choices. And we look forward to other discussions in the future. And once again, thank you very much.